Okay, next we're going to talk about obstructive defects. These are defects that cause obstruction to blood flow somewhere. So pause the recording for just a minute. Think about what's going to happen if blood flow somewhere in the heart is obstructed and can't go where it's supposed to go. So let's share. This is coarctation of the aorta. It's when the aorta has a spot that is narrowed, usually near the ductus arteriosus. What happens? Left ventricle contracts, pushes blood into the aorta, but it's got an obstruction here because not enough blood can get through. So pressure is high here, pressure is low beyond that point. Okay, so what do these vessels go to? These arteries that branch off before that spot go to the upper part of the body. So the upper part of the body, there's increased pressure. The lower part of the body, there's decreased pressure. We might see bounding pulses, and then lower body, we see weak or absent pulses. We may see even pallor because they're just not getting enough blood flow. This can lead to heart failure, especially in infants, because if the blood can't go forward, it starts to back up. Okay, from the left atrium, it starts to back up. The right ventricle can't get it into the atrium because there's too much pressure. So blood backs to the right atrium, then it can't get to the right ventricle, backs up, they end up with heart failure, right? Just because too much pressure. If this is severe, if their blood flow is severely restricted below this point, they can develop acidosis from ischemia, and that can actually lead to severe hypotension. Older kids may feel dizzy, they may have headaches, fainting, or nosebleeds because of the increased pressure going to the upper body. There's a risk of hypertension, ruptured aorta, aneurysms anywhere in the upper body that those vessels go to, and stroke, all because of that increased pressure. So surgery is advised within the first 2 years to prevent chronic hypertension. And what they do is resect it. They remove that little section that's really tight, and then they reanastomose those two pieces. Okay. If there's not enough space to reanastomose, they can use part of the subclavian artery for a graft. Cardiopulmonary bypass is not required for this surgery. During the recovery period, we really have to avoid hypertension while this is healing. We don't want to subject these incisions to increased pressure. So hypertension is managed with meds during recovery. Non-surgical treatment, they actually can do balloon angioplasty. They use a heart cath procedure, and you put a balloon into this space and try to stretch it. If that's used as that may be used as a primary intervention or to treat recurrences if it happens again. The prognosis, mortality is less than 5% if there aren't any other defects, but this can come back if they have it, it can actually come back once it's been treated. Okay, we're going to move on to aortic stenosis. So I want you to take a minute, pause the recording, make sure you understand coarctation of the aorta really well. Next, we're going to talk about aortic stenosis. So where is the aortic valve? That's the one that goes from the left ventricle into the aorta, right? Stenosis means it's narrowed, it's stenosed, it's narrowed or restricted. So this is a stricture or narrowing of this aortic valve. So if this, we can see here it's from hypertrophy, but it can also just be really tight. If this valve is too tight and it doesn't allow blood flow to go through, what happens? Decreased cardiac output, so we have less blood going out to the body, but if it's not going forward, it's backing up into the lungs. So pulmonary congestion, and this left ventricle keeps having to work harder and harder and harder. And so when muscles work harder, they get thicker. So we have left ventricular hypertrophy. If this muscle gets really thick, it doesn't have room to hold enough blood. That ventricular hypertrophy leads to pulmonary hypertension. because it actually affects, it's pushing more blood back into the right side of circulation. Okay, sorry about that. So if this ventricle is hypertrophied, that can actually lead to pulmonary hypertension. But it also means that it's harder for, it can actually constrict the vessels that are going to the muscle of the heart. So that leads to a risk of heart attack, MI. And because of that muscle damage, the mitral valve can be affected as well. So the longer this goes on, the more damage happens because of it. There are two types. Valvular means the valve itself is stenosed, usually because it's not formed correctly. Or subvalvular is when there's a stricture below a normal valve. So the valve is normal, but there's a stricture below it that doesn't allow blood to get into the valve or to get out through the valve. What does this look like? Well, we've got less blood going out, so decreased cardiac output. Exercise intolerance. When they try to do anything, they may have chest pain and dizziness because they can't increase blood flow to handle the needs of that movement. They may have a murmur. They're at risk for bacterial endocarditis because this messed up valve is a place for bugs to grow. They're at risk for coronary insufficiency, the heart, the coronary arteries not being able to consistently get good blood flow to the muscle tissue. So that's going to cause chest pain and with exertion. They're at risk for ventricular dysfunction. The ventricle just doesn't work correctly because it gets so thick from trying so hard to get blood through that valve. Surgical treatment. If it's valvular, if the problem is the valve itself, they can actually just go in and cut the valve. That's considered a palliative treatment, or they can do a valve replacement. If the patient is not a candidate for valve replacement, if they just open that, do a valvotomy and open that valve more, it relieves the symptoms somewhat, but it doesn't fix the problem. Subvalvular, if it's not the valve itself, but adjacent to it, then they may be able to correct that stricture. Non-surgical treatments, they actually can use balloon angioplasty, that's using the heart cath. They can use that balloon to try to dilate. And if it's a valvular constriction, they usually try to do that first. If that doesn't work, then they may try to replace the valve. Without treatment of valvular aortic stenosis, so if it's the valve itself, if it's not treated, this patient's at risk for sudden cardiac death. So they need treatment. If the problem is subvalvular and they have surgery at a major center, the mortality's 5%, but there's a 20% chance of recurrence. Okay, the last obstructive we're going to talk about, let's actually take a minute. I want you to pause. I want you to pause and go back through aortic stenosis. Okay, make sure you understand it. And then we're going to look at pulmonic stenosis. So if aortic stenosis is stenosis of the aortic valve that affects blood flow to the rest of the body, what do you think pulmonic stenosis is? You're right, it is stenosis of the pulmonic valve. So if we can't get blood through this pulmonic valve to the pulmonary arteries, then we cannot get blood oxygenated effectively, and that's a major problem. But also this ventricle is just working so hard trying to get it in. So we have right ventricular hypertrophy. That actually leads to higher pressure in the right atrium and can reopen the foramen ovale in a young baby, a newborn. If that happens, then we have deoxygenated blood shunting over to the right side or to the left side, a right to left shunt. Okay. Now, if they have a patent ductus arteriosus, remember PDA, If they have that, this actually may help to compensate for this problem, because pulmonic stenosis is a major issue. We can't get blood to the lungs to get oxygen. And so we have less blood going back into the atrium, but what's there, we have all this deoxygenated blood backing up. But if they have a PDA, then they can sometimes, that can help get some oxygenated blood back into the system. So I want you to think about why, if the opening is between the atria, they have a right to left shunt. But with this pulmonic stenosis, if the ductus is open, so it's between these arteries, it's a left to right shunt. Okay, I want you to think through that for just a minute. So if the problem is here between the ventricle and the pulmonary artery, this valve is too tight. Okay, so if this valve is too tight, blood backs up, the right ventricle can't push the blood forward. So we have blood regurgitating into the right atrium. Okay, reopen the foramen ovale, and there's a lot of pressure here. So that pressure is pushing the blood over, right? But if we're not getting enough blood through here, if this baby still has a patent ductus arteriosus, we have low blood pressure past this valve because we can't get blood through there. So now we're going to have a left to right shunt, and that can actually help the baby stay oxygenated until this is fixed. Now, if this is mild, they may actually be asymptomatic. And if they have symptoms, they may have stenosis or heart failure. But these tend to get progressively worse. So as they get worse, their symptoms get worse. Sometimes they have a murmur. Sometimes their heart is enlarged. They're at risk for bacterial endocarditis. Now, if instead of just tight, if this is complete atresia, they have to keep these artificial or these fetal pathways open to get oxygenated blood until they have surgery. Okay. Surgical management of pulmonary valvotomy, they can incise this valve to make more room. Surgical treatment is a lot less common because they're much more often use balloon angioplasty. So they can do a heart cath, dilate this valve, fix that problem. The mortality for this is actually low if it's treated.